Dear colleagues, this is Phaco emulsification of a soft cataract. This is a totally unedited surgery. Let's watch the surgical steps. This is the main incision. It's a 2.8 millimeter posterior limbal incision. You can see oozing of blood from the site of incision. Now, viscoelastic substance 2% hydroxypropyl methyl cellulose is injected into the anterior chamber and it is sprayed over the corneal epithelium for better visibility. And now, this is a side port about 3 clock hours away from the main incision, and this is another side port about 3 clock hours on the left side. Now, this is capsular axis. The anterior capsule is incised, a capsular tag is raised. This capsular tag is held with a utata forceps. I go anti-clockwise. I remain at a certain distance away from the margin of the pupil all around, and thus I do a continuous curvilinear capsular axis. It is not always circular, but it is a continuous axis in almost 99.9% cases. And now, hydrodissection. Fluid wave is passed just underneath the anterior capsular rim. It goes from one side to the opposite equator. The nucleus is gently tapped and it is rotated. And now is the time to introduce the tip of the Phaco handpiece. Little bit of viscoelastic substance is injected. The machine being used in this case is Oddly Cataract 3 Phaco machine. Dear colleagues, this is a totally unedited surgery and you are going to watch each and every step of the surgery. We must remember that this is a very soft cataract, so vacuum is reduced to 300 mm of mercury, flow rate is 30, and power, Phaco power in this case is only 35%. The tip of the Phaco handpiece is buried and without applying vacuum, just making the nucleus stable, the chopper is used to slice the nucleus. The nucleus is emulsified and removed. Since this is a very soft cataract, emulsification is easy. All the emulsification should be done at the center of the anterior chamber, at the anterior capsular plane. That's it. Now, viscoelastic substance is injected again, at this time to protect the corneal endothelium and to maintain the anterior chamber, since I am using a Simcoe cannula 23 gauge. This is a very simple, very safe instrument. Just remember that you must hold the anterior portion of the cortex, that is the cortex that is just underneath the anterior capsular rim. Hold that portion of the cortex, pull it towards the center and then remove it, suck it out. There are 2 air bubbles. Little bit of cortex is still there at 1 o'clock, it is removed. Now some cells are still sticking to the posterior capsule that must be nicely polished. Simcoe is not a good instrument for polishing the posterior capsule. So I take the irrigating probe of bimanual IA and sweep it over the posterior capsule. The irrigating jet of fluid is swept over the posterior capsule, and see how beautifully the posterior capsule is polished. In this case, a hydrophilic acrylic intraocular lens has been selected for implantation in the capsular bag, and here it is. And hydro is being used, that is irrigating fluid is being used to keep the antechamber formed, and the IOL is placed in the capsular bag. So the lens is in the capsular bag now. The irrigating probe is being used to dial the lens. The capsular bag antechamber is flushed out. This is a bit of moxifloxacin. Now BSS is used to hydrate the stroma on either side of the side ports. This will cause closure of the side ports. The side ports are never stressed in my surgeries, so it closes nicely. And here it is. This is the final lavage of the anterior chamber. The anterior chamber is formed and the case is concluded. Thank you very much for watching. Hope this video will help you in developing your surgical skills.